Hi, I'm Sue Morris. I'm a clinical psychologist and the Director of Bereavement Services at Dana-Farber Cancer Institute here in Boston. Today I'm going to be talking about hospice care and caring for bereaved families in 2022. Just first of all, my disclosure is that I do receive author royalties for 2 self-help books about grief. So the objectives of the presentation today is to outline the nature of grief from a psychological perspective, to understand how the care of the patient, including hospice care, impacts family bereavement, and then to outline a framework for offering condolences to bereaved family members. I'll talk a little bit about the palliative care model and where bereavement sits in that, more about hospice care, then understanding grief, and thinking about the risk factors for when we would worry about somebody having a poor bereavement outcome, then what are the barriers to healthy outcomes, and then the impact of bereavement, the impact of the pandemic on bereavement, and then lessons learned from bereaved family members. And then I'll introduce you to a very short acronym called TEARS, which is a way for a framework for helping you offer condolences. So this is a model you may have seen. This is the palliative care model. And, it gives an idea about where serious illness fits in the model as well as bereavement. I tend to work in this green triangle, and most of you in your work will be somewhere in the red or the pink. And we know that for patients, the care that patients receive during their illness, and whether it's therapy going into palliative care and end-of-life care, all of that in the red impacts the bereavement experience of the family members. So, for example, in the case of a sudden death, such as, say, for example, a sudden infant death, there's no red, so there's no time to prepare. And that green triangle there is very huge. So we know that there's a lot that can happen in the red that impacts the bereavement outcomes for family members. So when we think about hospice care, and I'm sure, all of you have had some kind of contact with hospice care, but hospice is a model that serves patients with a terminal illness, resulting in a life expectancy of 6 months or less, as determined by the patient's physician. It's considered to be the model of quality, compassionate care at the end of life. And hospice care really involves a team approach of expert medical care, pain management, with emotional and spiritual support tailored to the patient's wishes. And just like in that red, in that diagram with the pink, hospice care focuses the shift from, finding a cure to providing comfort. The emotional and spiritual support that is, given to the patient also is extended to the patient's family and other loved ones. Generally, care of the patient is provided in the patient's home or in a home-like setting operated by the hospice program, and that's usually referred to like a hospice house. The team works to develop a plan of care and to provide services and support that will enhance the quality of life for the patient and family while respecting their wishes during the final phases of illness and then the bereavement period. I used to work in hospice here many years ago in Boston. And, bereavement then is offered to families for, 12 to 13 months after the death of the patient. So bereavement is very, central. It's a core element of hospice care, and it's a central component of high quality end-of-life care. So we very much see that the care of the patient extends to the care of the family during their bereavement. And research demonstrates that the provision of palliative care and hospice services is associated with enhanced family satisfaction and improved bereavement outcomes. And that kind of gets to that kind of red triangle, the red in the triangle diagram. It's it's the importance of preparation and clear communication. And I think I would just stress there that in serious illness and, palliative care and hospice care, it's helping families prepare, not just practically, but also psychologically or emotionally. So I now just want to talk a little bit about bereavement in context. And I'm talking very much about bereavement in kind of Western society. that we know that the death of a loved one is believed to be the most powerful stressor in everyday life. And that certainly is a universal experience. Bereaved individuals have higher rates of disability, medication use, and hospitalization than their non-bereaved counterparts. So in the US, approximately 2.8 million people die each year. That's prior to the pandemic. And we estimate that somewhere between, around 5, maybe 5 to 10 people are significantly impacted for the death of one person. So if we do the math there, that's a lot of people. And, probably of that number, 10% of the bereaved are estimated to experience suffering requiring some kind of professional intervention. And, I would argue certainly we're seeing and feeling the effects of it now through the pandemic, but, bereavement is often an unmet public health need because we don't really have a lot of, places that are easy to find that you can just go and get bereavement support. Hospice, as I mentioned, is certainly one place, but often people don't really know that hospice bereavement is also available to people in the community, not just the people, the families of patients who have used the hospice. When we think about, the deaths of patients in hospitals, we can look at the bereavement. So there was a study done back in 2010 now with Dr. Alexi Wright, who's an oncologist at Dana-Farber, who looked at the impact of hospital deaths versus deaths at home with hospice for cancer patients. And what this study found was that there was an increased risk of prolonged grief disorder for families of cancer patients who die in the hospital. And then when they looked further, there was an increased risk of post-traumatic stress disorder for families of cancer patients who die in the ICU. And that kind of logically makes sense because we know that ICUs are, fast-paced, very medically, technologically driven kind of systems of care that can be pretty scary to people who aren't familiar with an ICU setting. Then in 2016, in a more recent study, it looked at the levels of complicated grief, PTSD, and depression in bereaved families of patients who died in the ICU versus a non-ICU setting. And what this study found was that there were no differences between the settings where the patient died, but they did conclude that the most distressing experiences in either the ICU or a non-ICU setting highlighted the need for intervention to reduce the distress of bereaved family members. And I think this is, very important, in kind of the care of patients, but particularly now during the pandemic where many patients have died in an ICU setting. So as a psychologist, I have a prevention hat on when I meet bereaved family members. We want to think about how do we support families, even when the patient is still alive, through this prevention lens, because it's very much a model of preventative care, certainly in the early, weeks and months. So from a psychological perspective, grief is defined as the anguish after significant loss, characterized by deep sadness and yearning or longing. I'm actually originally from Australia, so I would say instead of yearning, I would use the word pining. That grief is characterized very much by a yearning, a pining, a longing. They all mean the same thing, and it really gets to the heart of, missing somebody, which is very much hardwired into us. We don't have cognitive ability to say, I'm not going to yearn today for the person in my life who just died. We can't think ourselves out of it. And I'm sure for many of you listening to my talk today, we're not immune from grief ourselves. If you've recently lost someone in your life who you love, I'm sure you can relate to this, that this yearning is something very primitive. It's hardwired. It's all to do with attachment. We grieve people we're significantly attached to. And this grief experience, associated with the death of somebody, because obviously you can have a grief reaction associated with other losses, such as, the end of a relationship or being diagnosed with a serious illness. But in relation to the death of a loved one, grief is a very intense physical and emotional reaction. I think most people, expect that grief will be emotionally challenging, but they underestimate how physically stressful grief is. It's very, very taxing, which is why I always encourage my bereaved family members who I first meet to make sure they're checking in with their local doctor, just who can, keep an eye on things. But even though grief is very, very painful, it is a normal response to loss. So we have kind of grief over here, and we'd have, depression over here. But there can be a lot of overlap in those first, weeks and months of acute kind of symptoms. Grief is very much a period of adjustment. It follows a wave-like pattern. And the research indicates that the intensity of this grief reaction slowly subsides, usually by about 6 months, with ongoing triggers that result in kind of an intensification of emotion. Now, I think I just need to stress here that this is research based on spousal loss that kind of indicates this 6 months reduction in the intensity of the emotion. We know for bereaved parents, for example, their grief experience lasts for many, many years. And whilst that's kind of normal, we certainly would still want them to have kind of the support that they need early on. Again, in our Western society, we have to think about grief as being very grief within the context of our society, which is technology-driven, fast-paced, sense of control, and we have a fix-it mentality. And this is certainly true prior to the pandemic, where we think, we have control. And obviously the pandemic has challenged this kind of belief of the world we live in, but so does the diagnosis of somebody we love with a serious illness and then their subsequent death challenges this kind of view that we have. Normally I don't meet with bereaved family members until after the death of the patient. And sometimes it can take, especially when people had to drive into the office to meet me. Now I'm kind of using Zoom, so people get to access bereavement support earlier than they may have when they had to return to the institute to seek bereavement support. But many people would come back in a couple of months later and they'd kind of say something like, I thought I'd be better by now. And this kind of indicates where their expectations of their progress kind of are. And for many people, when they say something like, I thought I'd be better by now, it indicates that their grief is linear. It indicates that they thought or they expected that as time went on, they would just get better and better and better. And that is an inaccurate model for grief. It probably, I often say to the medical students that it is more an accurate model for say an ear infection. From a very young age, we go to the doctors if we have an ear infection, we get antibiotics. If we take them properly, we have a linear response. And that's kind of how we grow up, and we hold that view in the back of our head somewhere. But it's an inaccurate model for grief, and it takes people down the wrong path. Whereas grief is much more this wave-like pattern. And, it's a simple representation here, and I've tried to draw it as best I can. But if you can see that in the beginning, when the death occurs, these waves of grief, which are this very intense pain, sadness, and this yearning, happen very, very fast. There's not much downtime in between waves. But over time, the waves tend to lessen in intensity and frequency, and they trend back up again around the first anniversary. I would probably say there that, at the first anniversary, grief is less raw than what it is at the beginning, because people cope, they learn coping skills. And then you can see the little dotted red lines. They're what I call trigger waves. And many people have many different triggers. There's an infinite number of triggers. But they can be something like, hearing a song on the radio or bumping into somebody who hasn't yet heard the news that their loved one died. Those triggers can kind of catch you off guard out of the blue. But then there can also be trigger waves that you can anticipate, such as a birthday or the holidays or a wedding anniversary, for example. But it's just a very helpful model because everybody has their own wave of grief. And even two people in the same family grieving the same person will have a different wave of grief because they have different triggers and people cope in a way that's fairly consistent with their personality. If there's somebody who wants to be quiet and mull things over themselves, they'll probably be quiet in their grief. Whereas if there's someone who normally likes to talk through problems or worries with other people, they'll probably seek out wanting to talk to people. So the wave-like pattern just helps people have an expectation about what their progress over time may be like. What I don't show here on this graph, which kind of matches the pink on that original diagram I showed you, is that there's always the roller coaster of the illness trajectory. So for serious illness, everyone's going to be on a roller coaster. And we see in oncology, for example, that, you know, if somebody's been on a clinical trial, they may get their hopes up, may do well for a while, then their hopes may be dashed as things don't turn out. There may be an option of another treatment. So there's this kind of roller coaster pattern. If somebody, for example, has an accident and comes into the hospital, there's not really any time there to prepare. Their roller coaster may be that somebody's in surgery, they've got their hopes up, and then something happens and, you know, the patient doesn't survive. So the roller coaster definitely impacts the bereavement, kind of this wave-like pattern. So the idea then is, when I meet with people in the world that, you know, I work in, my idea when I, you know, say to people, I can't fix anybody's grief. You know, grief is something we can't fix. I can't bring back somebody from death. But the idea then is, well, what is the goal of bereavement support? And it is to help people learn to ride the wave. You know, there's strategies that we can help people learn to tolerate this up and down pattern. But really, the whole wave of grief, and that, you know, certainly that first year of somebody's life after somebody dies, is about navigating change. The wave is really a wave of change. So often people get stuck on how long they knew the person who died. So if somebody, say, for example, has been married for, you know, 60 years and it's one spouse dies, yes, they've known them for a long time. There's also a lot of change because the surviving spouse may have to, you know, move into different accommodation, for example. Similarly, the work that I do on the sudden infant death program at Boston Children's Hospital, Robert's program, parents haven't known their babies for very long when they die of a sudden infant death. But the change is huge because it goes back to what they expected their life to be. So we want to always think about how much does somebody's life change after somebody dies. So when we think about the risk factors for poor bereavement outcomes, so again with my prevention hat on, these are some of the common risk factors. There are others, but a history of psychiatric disorders, including depression and substance use, is a risk factor because often a death can trigger a depression for people who have suffered from depression. Lack of or poor social support, because grief is very isolating, even in the best of times, because, you know, you can only grieve yourself. And certainly with the pandemic, we've seen that isolation factor from social distancing has really magnified the isolation that people usually feel in bereavement. Other stresses, concurrent stresses, whether somebody, you know, cannot work, certainly if, you know, they've got to move, lots of other things that can be kind of causing stress. Previous losses, you know, maybe they've had a lot of other loss in their life. Lack of preparation for death, that's particularly important in that, you know, unexpected death. But it's also, even if someone's been ill for a long time with a, you know, serious illness, people can still feel unprepared. Unexpected diagnosis, a sudden death, a highly dependent relationship with the deceased. That doesn't necessarily mean a negative dependency, but just gets back to how much does someone's life overlap, such as that, you know, 80-year-old couple who have been married for a long, long time, you know, we all complement each other in relationships. So there can be a dependency that is upended when somebody dies. A death of a child is always a risk factor, especially the death of an only child. Witnessing a difficult death. Now this, you know, goes back to some of that ICU research. I think it's important to note that during the pandemic, even if family members weren't with their loved one when they died, certainly what we saw on TV early in the pandemic about ventilators and what the hospital system might look like, that can, you know, what people imagine it could be like would also be equally worrisome as a risk factor. And then obviously a violent death that you might see in the case of, you know, homicide or an accident, something like that. So I now just want to quickly talk about the difference between grief and depression, because they can look very similar in the beginning. Like I said, we have depression over here that is something we would want to treat. And then we have grief over here that is a normal response to loss that feels very, very painful. So depression is especially major depression, is a medical illness. And it's characterized by, persistent sadness, a loss of interest in activities, guilt, worthlessness, hopelessness, often suicidal ideation. And bereavement-related major depression is most likely to occur in individuals with a history of depression. It's, you don't typically see that yearning quality in depression unless somebody is depressed because of somebody has died. Whereas grief over here is this normal response, but it's very, very painful. And as I said, the painful feelings tend to come in waves, but they can usually be mixed with positive memories of the deceased. And self-esteem tends to be preserved, and some form of depression is normal. As I said, some form of those early depressive symptoms, such as, difficulty concentrating, loss of appetite, difficult sleeping, certainly in those first weeks and months. But we want to prevent that grief from turning into anything more serious. So what are the barriers then? What are likely to get people stuck? If we think about that wave of grief, what is that we hopefully trends down over time, what's likely to kind of be a barrier to that or kind of get people stuck somewhere in that process? Lack of acknowledgement of a death. We live in a society where we very much acknowledge death. We send sympathy cards. We expect people to offer condolences. And so when there is a lack of acknowledgement, especially from providers, a medical institution, people can feel like they've been abandoned. Distressing feelings, guilt, regret, anger, certainly seeing a lot of these are magnified during the pandemic. People, family members can feel guilty that maybe their loved one got COVID because of, from them. They may have regret about treatment decisions. There can be anger at, obviously an illness. There can be anger at providers. Certainly I've seen a fair bit of, anger directed because of the visitor policy at the hospitals. There can be also these difficult memories associated with witnessing a death. Decision or regret is often a barrier. Why did we do this? I don't understand why things happen so quickly at the end. I thought this was happening and then this changed. So people, often it's kind of like torment. It can go round and round and round in their head, which also, relates to unanswered questions. And we see that when somebody dies from, an accident or suicide, there's often a lot of unanswered questions as to how did this happen? On unresolved differences or conflict with the person who died, avoiding certain places or people, and then having difficulty making decisions. Often when someone dies, someone may have to move. There may be a lot of decisions about financial decisions, things like that. That just all adds to the stress because it relates to the change. So just kind of in the few minutes that I have left, I wanted just to talk a little bit about the lessons learned when we've interviewed bereaved kind of caregivers. What people say, family members say, before a death, they want their providers to show compassion to both the patient and the caregiver. They want people to be upfront and honest. They want to kind of have a more of a roadmap, if you like. Provide clear and accurate information about the dying process to aid in decision-making. Facilitate opportunities to say goodbye and to participate in providing end-of-life care. For providers who, work, with serious illness, early referral to palliative care and hospice is, certainly what family members wish happened. This may not be necessarily your roles, but if people are on a team, screen for risk where possible. If you're worried about a family member, you think they're not going to cope well, try and make an early referral or get social work involved, something like that. And for people who have had some contact with families for some time, and and the patient, it can be really helpful to check in with the family and the patient when they've been discharged home with hospice, prior obviously to their death. But then after the death, you want to send a letter of condolence if you had a relationship with the family and the patient. We would consider that an essential component of quality end-of-life care. Include a personal memory if you knew the patient well, and if appropriate, mention a good job the family did in caring for the patient, because usually families beat themselves up afterwards and they second guess whether they did everything they could have. We should have done this. Make a bereavement call, check in, make recommendations about support, especially, mentioning, checking in with their local doctor. Provide opportunity as a team to answer lingering questions and to say goodbye. If someone dies suddenly under your care that you didn't expect them to die, it can be very helpful in the person's bereavement, the family's bereavement, to have some opportunity with the team to answer those questions, to understand what happened. If you leave a voicemail, express condolences with compassion and don't rush. And pass the baton to the bereavement team if you work in an area where there is a bereavement team. So just kind of from the COVID-19, bereaved individuals, like I said, are likely to be more isolated, express condolences, offer opportunities to meet, to answer questions about the death, and acknowledge that we're in an unprecedented time. That kind of helps people understand that they didn't have complete responsibility or control over what was happening with their loved one. People need to tell their story, so making sure you've got time to allow them to tell their story. If somebody is, responding, is talking to you about how hard it has been since their loved one died during the pandemic, respond to emotion. Once people get upset, it's really important to respond to emotion first and then name the pandemic, such as, I hear how devastating this has been for you and your family. This pandemic has caught the entire world by surprise. No one saw it coming. Something that kind of allows, that you understand and meet them where they're kind of how emotionally challenging this has been. Encourage the bereaved to seek support and engage with family and friends via technology. Hopefully things are easing up a little bit and more people are getting together in person as we're able, but still technology is a very important part of connecting and tackling that isolation. And then for you as providers, this is really hard work. We've all been through a very challenging time over these last 2 years where our jobs, we're doing our work in different ways than we would have done before. It's very important to debrief with colleagues as this is hard work, because it's not always possible or appropriate to take your work home. And then just to finish, if you are in a position to reach out to families, outreach humanises the relationship, especially in big organisations and institutions. We don't want people to feel that their loved one was just another number. Offer condolences. I really believe not only does it benefit the family, but it also benefits the clinician. If you have a lot of patients who die, or even if you don't, taking the time to make a call or send a sympathy card is really important. The opportunity, as I said, to answer questions and to say goodbye. If someone's been seeing a provider for a long time, and we see this in oncology, they get very attached. Dana-Farber, for example, as many other institutions would become, they kind of become like second family, the team. So it's really important to be able to acknowledge that transition and then to be clear about future contact or follow-up, because that helps to manage expectations. I always say to people, don't promise anything you can't deliver. And then just finally, the TEARS acronym, which was published, we published this in an article for the pandemic. It's an acronym about offering condolences. T stands for timing. The E stands for expressing condolence. A stands for asking questions. R stands for recommending. And S stands for saying goodbye. So the timing, if you are going to call somebody to offer condolences and check in, ideally you call within the first couple of weeks. If you don't find out till after, then you do that too, and you just acknowledge that I've only just recently learned. Express condolences. I'm very sorry to hear. And expect emotion. They don't know you're calling, so expect them to, maybe be sad. Ask factual questions, because they're usually easy to answer. Is anyone staying with you? Recommend the primary care physician or the team meeting if they've got lingering questions. And then say goodbye, a final goodbye, or I'm available to answer any questions in the future if they arise. So you can read more about that in that article if you would like to know more. But I do suggest to people to offer condolences. So just to wrap up, bereavement care is best conceptualized as that preventative model of care We know that the care of patients from diagnosis to the end of life impacts the bereavement experience, and feedback from families about patients' care provides important insights about ways to improve future care. Thank you very much.